Hi, thank you. Hi, good morning, everyone. It's a real pleasure to be here. Thank you to Helen and the MMF Organising Committee for organising this conference. A warm welcome to everyone, patients, their carers. A very warm welcome also to Jesus and Vincenzo, and coming from Spain, and our other international guests from Thailand. So, I was asked to talk about how far have we come, and also to give a general basic overview of cholangiocarcinoma. So cholangiocarcinoma is a cancer, an abnormal growth of cells that arises within the biliary system. So what's the biliary system? The biliary system is a network of tubes through which bile flows. So bile is this greeny fluid that the liver makes, which flows through the bile ducts and eventually into the intestine. And bile is important to help digest food and to get rid of waste products. And so cholangiocarcinoma is a cancer that arises somewhere within that network of bile ducts. And that network starts off in the liver and then gradually coalesces into tubes that leave the liver and go into the intestine. So this is the area we are talking about. So parts of the biliary system, or the bile ducts within the liver, is called the intrahepatic biliary tree. Where the bile ducts coalesce outside the liver, just outside the liver, is called the hilar area. And then the part of the main bile ducts, so it's like a sort of network of small roads that become an A road and then a motorway. And the M1 is the common bile duct that takes the bile into the intestine. And cholangiocarcinomas can arise are broadly classified into those three anatomical areas, depending on where we think they've arisen. There's some CT scans. And the interesting things are that in clinical practice and clinical case series reviews, the largest of those three groups is what's called the perihilar cholangiocarcinoma, with smaller numbers arising within the liver or outside the liver. So there are three distinct anatomical variants of cholangiocarcinoma. And they are different not just anatomically, but they do have differences in how they present in their clinical features. Sorry, the timing is a bit out of sync. The risk factors, how we diagnose them, and how we treat them. So there are subtle but important differences between those three. How does cholangiocarcinoma present? Although, and you'll hear from Sophie's data presentation in a bit, there are increasing numbers of younger patients. The majority of patients are in slightly older groups and have no family history of liver disease. Around 20 to 30% of patients have a background chronic liver condition called primary sclerosing cholangitis, which is a sort of autoimmune sort of condition. We don't really know what causes it, but it causes inflammation of the bile ducts. Many patients will just have abnormal liver tests. Now, abnormal liver tests, which measure things the liver makes or gets rid of, are extremely common, and there are many, many causes of abnormal liver tests. And sometimes abnormal liver tests are just picked up incidentally. Someone's had a blood test for some entirely different reason. And some patients may have no symptoms, but the symptoms, or they may have symptoms depending on where the cholangiocarcinoma is. So if the cholangiocarcinoma is obstructing a major duct, the perihilar area, or just outside the liver, patients may present with symptoms of the bile flow being blocked, biliary obstruction, and that can cause jaundice, usually painless, pale stools, dark urine, and itching due to the buildup of toxins in the bile in the body. If the cholangiocarcinoma arises within the deep meat of the liver, there's often no specific symptoms. There might just be a general feeling of malaise, maybe some weight loss, maybe some vague discomfort. And that's why cholangiocarcinoma can be very difficult to diagnose, and why it often presents very, very late. How do we make a diagnosis of cholangiocarcinoma if the suspicion has been raised? Well, the history is very important always. Blood tests, we have some tumor markers. The main one we look at is something called CA19-9 in the blood, but that's not specific for cholangiocarcinoma. Various imaging techniques, usually starting with ultrasound, CT, MRI scans, endoscopic ultrasound, ERCP, PTC, so ways to look into the bile duct, and then histology, biopsies or sampling from the abnormal area. There is no one definitive diagnostic way. Histology is what we really rely on, but sometimes, depending on where the tumor is, it can be very difficult to get histology, just because of the anatomical location. So diagnosis can be very challenging. What treatments do we have? The only potentially curative treatment is surgery. That's transplantation is something you'll be hearing a little bit about more later. Local treatment, so ablation or radiation. The majority of patients, when they present, unfortunately, have quite advanced disease, and it's beyond the cancer burden is too far for surgery, and so they need systemic treatment or chemotherapy. And the mainstay of treatment is endoscopy to relieve any obstruction in the biliary tree to improve symptoms, but also to allow the liver function to improve and therefore allow other treatments to proceed. So that's just a little bit of background about cholangiocarcinoma. So I wanted to talk about how far have we come. So when I was asked to talk about how far have we come, one needs a starting point. And an obvious starting point was 2002. So I started my PhD on cholangiocarcinoma in 1999. So in 1999, I was a registrar, a junior doctor. I was keen to do a PhD on something because I thought, well, I'll need a PhD if I want to get a consultant job. That's really the only reason I wanted to do a PhD, really. I wasn't that interested in academia. The great Simon Taylor Robinson, Professor Taylor Robinson, who was my mentor for much of my career, who unfortunately can't be here today, I knew him as a junior doctor. He was a young consultant, senior lecturer at Imperial, and I'd actually left medicine. I'd actually taken a year out, and I was sort of traveling, got married, and then ran out of money, and then worked for a drug company for a bit, and then thought, actually, I quite like the NHS, and I came back. And Simon asked me what I was doing, and I told him I wanted to do gastroenterology. And he said, do you want to do a PhD? I said, oh, I'd love to do a PhD. And I'm hoping it'd be some exciting topic like viral hepatitis or inflammatory bowel disease. He said, it's on cancer. And I said, oh, cancer, that's really exciting, because I did an undergraduate degree in immunology. And he said, yes, it's liver cancer. He said, I want to do a project on cholangiocarcinoma. 1999, I said, cholangiocarcinoma. I said, are you nuts? I said, there's no one gets cholangiocarcinoma. If you live in Thailand, it's an issue, but I want to be a UK hepatologist. There's no interest in viral hepatitis is the way it says. No, he said, cholangiocarcinoma is an interesting area, and it's going to develop. And there was some funding, so when you're doing research, you follow the money, really. And so I said, okay, fine, this funded project, I'll do it, right? And I started my PhD in 1999, and I completed it in 2002. And 2002 was 20 years ago, and was also the year that AMMF was founded. So it was like we were soulmates without really realizing we were going to be soulmates. At that time, I hadn't met Helen or the AMMF. So what I'm going to talk about where were we in around 2000, 2002, where are we now, and where do we need to get to? Looking at those areas specifically: epidemiology, surgery, radiotherapy, systemic treatment, endoscopy, NHS development, some science and collaborations. Okay, I've got a slide on each. So where were we in 2002? Well, as I personally felt, cholangiocarcinoma was not a major problem, and I did the PhD because there was some funding. There were no published studies, to my knowledge at that time, of epidemiology of cholangiocarcinoma. We were taught at med school, it's a problem in Thailand. You don't need to read about it for finals because it's not going to come up because it's so small print. I didn't even really read, I just knew liver flukes, Thailand, that's all I needed to know as a medical student. We had no idea how many people were affected really, and we didn't know really about risk factors apart from liver flukes in Thailand and PSC in the Western world. And that was only a minority of patients. So that's 2002. Where are we now? Well, Simon Taylor Robinson and our group published the first studies showing rising rates of intrahepatic cholangiocarcinoma in England, in the UK, internationally, and there are now dozens of studies reporting the epidemiological trends of cholangiocarcinoma. Work from HCC UK looking at primary liver cancer a couple of years ago showed that almost 40% of all primary liver cancers, which everyone thought was all HCC, were actually intrahepatic cholangiocarcinoma, which was a major, major finding. We now have unmasked errors in the way cholangiocarcinoma is coded by the World Health Organization's International Classification of Diseases, and we have much greater knowledge of risk factors. So this is a paper from a review led by Professor Benales, looking at, so these are all the information we have on the international epidemiology of cholangiocarcinoma, many, many studies, the most recent of which, well, I've got one coming up, hopefully published in a few months' time, but the Bertucci et al.'s paper from 2019 showing rates of intrahepatic cholangiocarcinoma. One line is men, another line is women in multiple countries around Europe, the European Union, Japan, Hong Kong, Australia at the bottom, showing ongoing rising rates of intrahepatic cholangiocarcinoma. In terms of risk factors, so we knew about these 20 years ago. We now know that PSC aside, hold on, let me just get to family history is not a particularly known risk factor, but we now have a lot more information about other risk factors. And we now realize that some risk factors favor or are worse for certain anatomical variants than others. So we have a lot more information about risk factors for cholangiocarcinoma, specifically that chronic liver disease of any cause is not just a risk factor for HCC, but is also a risk factor for cholangiocarcinoma. And risk factors for liver disease such as fatty liver, alcohol, cirrhosis of any reason. So where were we in 2002? We not really very far. Where are we now? We now know a lot more about the epidemiology of cholangiocarcinoma, but where do we need to get to? Well, after a lot of work, we have corrected the inaccuracies in the coding system, and they will be corrected in the next version of the International Classification of Disease, ICD-11. And we need to ensure that these correct codes are widely adopted, and that generally coding from all centers which feed back to cancer registries are accurate, not just in the code for the disease, but the code for the treatments. We need to have a deeper knowledge of the geographical variation. So it's one thing to say, okay, in this country, this is the incidence, but we've done that now. We need much more granular detail. We need to know, is there variation in the countries? Variations in the incidence, in the mortality, in presentations, and access to treatments. And Dr. Sophie Jose will be talking about some of this work in relation to our study. Most cases still have no identifiable risk factor, so that's an issue. And we also need to understand more about the genetic drivers of cholangiocarcinoma. What about surgery and transplantation? Where were we in 2002? Well, surgical resection was the only potential cure. Even after a complete resection, 5-year survival was still only about 40%, which meant that even when you think you've removed the whole cancer, you hadn't necessarily saved that patient. There was no adjuvant treatment, so treatment you give before or after surgery to try and reduce the risk of recurrence. There was none that existed. No one really was doing radiotherapy for cholangiocarcinoma, and everywhere in the world, pretty much, you were not allowed a liver transplant if you had cholangiocarcinoma because of the historical experience that if you did a transplant, patients didn't survive, the cancer just came back. So it was contraindicated. You couldn't get a transplant for cholangio. That was the situation 20 years ago. Where are we now? Well, surgery is still really the only chance of cure, but we are getting better and better at local regional treatments. There are multiple studies which have looked at ablation. Radiotherapy is now coming back in. We have now an established adjuvant treatment with capecitabine following the BILCAP UK-led study by Professor John Primrose and colleagues. We have novel trials of adjuvant, neoadjuvant treatments. And liver transplant has been established as a treatment for cholangiocarcinoma, initially in the US. And the UK Liver Advisory Group has said that liver transplant should be considered for cholangiocarcinoma within strict criteria. So we are a lot further along. Where do we need to get to? We still need to have improved outcomes from surgery. And Mr. Hassan Malik's going to be talking about surgery later in this conference. We still need to improve local treatments, and Professor Maria Hawkins will be talking about radiotherapy. So I apologize for the timing of these slides. I'm not sure what's going on there. And we need to establish liver transplant. We've not done it yet. It's all talk at the moment, but Mr. Raj Prasad from Leeds, who's him and Maria Hawkins are leading on establishing the transplant program, will be giving us an update in this conference. What about chemotherapy, systemic therapy, which is what the majority of patients will end up needing? Where were we in 2002? You can see why in 1999 I was a bit reluctant to do a PhD in cholangiocarcinoma. So where were we in 2002? There was no agreed standard of care. There were trials, but they were small, they were disparate, they weren't well organized, and we had virtually no knowledge of the molecular genetic drivers for cholangiocarcinoma. Where are we now? Multiple successful ABC advanced biliary cancer tract trials, large, well-designed, international, led by colleagues in the audience here, including Juan and John Bridgewater. In 2010, pivotal study to establish the still main standard of care, combination treatment with cisplatin and gemcitabine. And as Helen has said, very recent approval for pemigatinib for a subgroup of patients, but the fact that that has happened in itself is a very exciting development. Where do we need to get to? We need to improve targeted systemic treatment and improve outcomes. Professor Bridgewater will be talking about systemic treatment later, and we need to understand the molecular genetic drivers again of cholangiocarcinoma better to help drive more targeted treatment, and Dr. Shiji Kai will be talking about that later in this conference. Endoscopy, where were we in 2002? Well, ERCP, which is a standard procedure to access the bile ducts, to put stents in, to take brushings for diagnosis. The standard of delivery was really variable. I was learning ERCP at that time, and some people were very good at it. Some people just have a go at it and weren't very good at it. It's a very difficult technique to do. It's a very highly skilled procedure. Takes a lot of training. We were not doing endoscopic ultrasound, so ultrasound with an endoscope internally, and we had no accurate systemic biomarkers. And even when you did an ERCP and you got brushings or samples, the success rate of picking up cholangiocarcinoma was pretty poor, 20–30% yield. Where are we now? Well, HPB is within hepatology, and surgery is increasingly a specialized training program. It's a subspecialty in its own right. You have to be chosen to be trained in ERCP. EUS is increasingly developed and established. We have better diagnostic tools, we have better scopes, we can do spyglass with direct visualization of the bile ducts, we have spy bites to take larger samples, we have improved stent technology, we have started doing endobiliary treatments where you can do ablation via endoscopic stents for local treatment of tumors. We've got improved pathological techniques for detecting cancer cells and increasing the yield, but there's still no accurate serum or urine biomarkers. And there have been lots of studies looking at biomarkers, but we need accurate, clinically validated biomarkers because there are lots of small studies that say, well, this might be a marker. But we need wider access to and specialist endobiliary intervention, and Dr. Wadsworth will be talking about endoscopy later, and we need better pathology markers, and Professor Golding will be talking about pathology a bit later on. Okay, I'm nearly finished, guys. So 2002, where were we when it comes to NHS and guidelines? There was little interest in liver cancer management among hepatologists, liver specialists. No one really had any interest in liver cancer. We had very few, if any, specialist nurses. There were surgical nurses, but most patients don't get surgery. We had very few, no real dedicated medical oncologists who just did hepatobiliary, really. And there were no dedicated cholangiocarcinoma guidelines anywhere in the world, to my knowledge, at that time. There was a much better growing awareness, not just of primary liver cancer, but cholangiocarcinoma. There is increased focus on subspecialty training within all the specialties involved now, radiology included. We have more liver cancer nurse specialists focused on not just patients having surgery. We have liver cancer MDT clinics in many centers now. And in terms of guidelines, we have the British Society of Gastroenterology guidelines in 2002, which I was involved with. Then in 2012, and they're being updated again this year, we've had guidelines from ESMO, ILCA, and others. So it's become a far, far more important area. Where do we need to get to in terms of the NHS? Do we need to work towards centres of expertise? This is a topic of discussion, which is a bit controversial and difficult to achieve. That's something that we maybe need to consider. And finally, basic science. Well, in 2002, very, very few research groups had any interest in cholangiocarcinoma, but no one did, I don't think, as far as I knew. It was impossible to get major funding. Cancer Research UK, who are the biggest cancer charity, actively told me we're not interested in liver cancer. It's way down the list of importance, so you're not going to get any funding. I was told by my university seniors, well, you're never going to get any funding for liver cancer work, so maybe you should think of look at the BMJ job section, because there was just no funding for liver cancer. There was no dedicated cholangiocarcinoma charity, there were no patient groups. Where are we now? Well, we know all about the AMMF. It's directly funded cancer research projects with Public Health England, with Imperial, Liverpool, Nottingham, Edinburgh, Leeds, Oxford, Spain, UCL and others, the ABC trials. And a few years ago, a friend and colleague, Helen Reeves in Newcastle, who has an interest primarily in HCC, got a multi-million-pound grant from Cancer Research UK. It was not for cholangio specifically, it was really for HCC, but the fact that they awarded a multi-big million-pound grant means that the game has changed. We still need to go for large multi-center collaborative and international grants for both translational and basic cholangiocarcinoma research, and we need to work towards that. And finally, in collaborations, there was no dedicated cholangiocarcinoma body or representation in the Western world in 2002. We now have Cholangiocarcinoma UK. We are well represented in the NCRI HPB subgroup. Jesus Vincenzo led the creation of ENSCA. ILCA, the International Liver Cancer Association, has dedicated cholangiocarcinoma days. And EASL, the European Liver Association, which has its International Liver Congress, had no interest in cancer. Then they developed a EASL HCC conference, and that's now changed to EASL primary liver cancer to include cholangiocarcinoma. So in summary, where were we in 2002? It was a pretty crap place, really, to be honest. It was pretty poor. Where are we now? We're in a much better place. But where do we need to get to? We need to go much further. We need much earlier diagnosis. We need cure. And even better than cure, we need prevention. If we know the risk factors and if we know how to prevent it, that would be the ideal. So, sorry for going over time, but it was much quicker when I rehearsed it.
Thank you very much, Sahid.